نور كله تمام ماشي الحال تمام okay. Good morning, good afternoon, good evening, everyone. It depends which part of the world you are right now. First of all, I'm happy to welcome you to our 7th webinar about Scapuloclavicular fractures. We have a group of elite surgeons who are going to give us talks about this nice topic. So let me welcome Dr. Yasser Safouri from Cairo University and Dr. Mohammed Abdelal from Al Marg Hospital. Of course, Dr. Ashraf Muharram from Cairo University and Dr. Sharif El Ghamri from Al Salam International Hospital from Cairo, and Dr. Simon Lambert from HCLA Healthcare from London. I also would like to express my gratitude to Mina Eva Pharma, pharmaceutical company, who sponsored our webinar, and we'd be happy to have Mina Munir at the end, who will give us a talk about thiotacid. So I think it's time to begin our webinar, and let's begin with Dr. Yasser Safouri. You can proceed, Dr. Yasser.
Good evening, everyone. Acromioclavicular joint dislocations, classifications, and treatment. Disruption or dislocation of the AC joint occurs after a direct trauma on the shoulder, where there's disruption of the main ligaments joining the acromion to the clavicle. So in dislocations of AC joint, there's disruption of the main two big ligaments, the AC ligament and the CC ligament. The AC ligament is the acromioclavicular ligament. CC is the coracoclavicular ligament. It's a common injury, about 9% of shoulder injuries. It's more common in males and in athletes. It can be as a direct trauma or falling on the shoulder. So the main ligaments are the CC and the AC ligaments holding the clavicle to the coracoid to the AC joint. There's also motion in the AC joint, which can be gliding or rotation. There are stabilizing structures, which can be static or dynamic. Static are mainly the AC joint, which is responsible for the horizontal motion and stability, while the CC ligament is responsible for the vertical stability. The dynamic muscles are the main big muscles here, which is the deltoid and the trapezius muscle. So this is the vertical stability by the coracoclavicular ligament, conoid and trapezoid ligaments. As you see here, they have a broad footprint. Horizontal stability of the AC joint is through the capsule and strong ligaments, which are in the posterior superior part and anterior inferior part, and these are responsible for the horizontal stability of the joint. For our treatment, we follow the Rockwood classification, type 1, in which there is a sprain of the AC ligament, type 2, in which there is rupture of the AC ligament and sprain of the CC, type 3, in which there is rupture of both the AC and the CC with displacement of the clavicle superiorly, type 4, in which there is posterior displacement of the clavicle, type 3, type 5 is the same as type 3, but more displacement and tension on the skin. The last type is type 6, which is the subcoracoid type. To diagnose such injuries, we do an X-ray, standing position, and the beam is inclined about 15 degrees. This is known as the Zanka view. And we compare both sides, and we measure the distance between the coracoid and the inferior surface of the clavicle. Some authors and surgeons prefer weight-bearing X-rays to differentiate between the second and third type of Rockwood classification. Others do not agree because the dynamic stabilizers, which are the muscles contract, and you will not make benefit from this type of view. But what is important is the Alexander view, lateral view, which is a cross-body adduction view. This shows if there's any displacement of the clavicle posterior. As you see in the slides here, there's dislocation of the dynamic forces of the clavicle posterior. So this is important to diagnose the DPT, which is the dynamic posterior translation, in which the clavicle goes posteriorly. So therefore, we're going to classify type 3 into two types. A, which there is a stable in horizontal direction, type 3B, where there is horizontal instability. As you see here, the X-ray shows the displacement of the clavicle posterior. This is type 3B. Treatment is mainly conservative or operative. Conservative in types 1 and 2, and this is by sling and local measures. Surgical, we follow the Rockwood classification for the types of fractures and dislocations and the type of treatment. So therefore, there's an algorithm of treatment beginning from type 1 and 2, where is primarily it's non-operative by conservative treatment. Type 5, 4, 5, and 6, these are for operative treatment directly. So the dilemma here is on type 3. So in athletes, manual workers, or high demand patients, then we go for surgery. Otherwise, we go for operative, non-operative treatment with conservative treatment, and we follow the patient. Sometimes after 6 weeks, they still have some complaints and they are transferred into operative interference. This is for type 3. Therefore, there are two issues. First issue is early and late treatment. What is important? There's moderate evidence in the literature about early treatment, but most of them recommend early treatment. Others in a systematic review found that there's no difference between early and late treatment. Also, another issue is that we should diagnose type 3B. Otherwise, if all type 3 are treated conservatively, they found that 50% of them will have scapular dyskinesia, which means abnormal motion of the scapula on the thorax. This will end up with a sick scapular syndrome where there's pain and fatigue during movement. So surgical treatment, the aim of it is to repair the AC ligament and the CC ligament. And we have devices to help us to maintain the position of the AC joint until healing. These may be in two big groups, metal devices or suspension devices. Metal devices like the hook plate or the screw between the coracoid and the clavicle. They maintain the clavicle in space until there's healing of the ligaments. Suspension devices, mainly arthroscopically, which are used now, in which there is a suspension of the coracoid to the clavicle. This may be by synthetic material or biological, such as tendografts, or it may be dynamic by using the coracoid bone with its attached muscles directly on the clavicle. But what is important in this treatment is that we should consider treatment of the AC joint ligaments. So historically, most of the researchers were focused on treatment only of the coracoclavicular ligament. But recently, there's a great importance of treatment of the AC ligaments. Also, in a systemic review, they found that there's great improvement in clinical function after repairing the AC ligaments. Therefore, it's important to diagnose the DPT and early treatment of these cases by reduction of the AC joint in both vertical and horizontal planes. So there are mainly two groups which are used by most of the surgeons, which are the hook plates or the arthroscopic suspension techniques. The hook plate, in which you put the plate under the acromion, not in the joint, to maintain the position of the clavicle in relation to the acromion until there is healing of the ligaments. The advantage, we have perfect reduction in both vertical and horizontal planes, possibly of early post-operative movements. He can go back to work directly, low technical demands, no residual foreign body after removing the plate. The disadvantages that we do not treat glenohumeral co-pathologies, which are found in about 20% in patients above 45 degrees, and these are diagnosed only arthroscopically. Disadvantage that we should remove the implant in 4 months, and in some old generations of plates, there was a type of acromial osteolysis when they use the old type of plates inside the joint. So it's also important to know the type of plate you use. You should choose the plate which is outside the AC joint, and there are different heights so that you will not have over-reduction or under-reduction. The suspension devices, arthroscopically, they have advantages. First of all, very minimally invasive. And number two, that they can address the co-pathologies which are present in 20% of the patients. Disadvantages, there's more restrictive post-operative treatment. In some types of button use of suspension devices, there is retention of the implant, which may cause irritation. Also, there can be a type of fracture of the clavicle or the coracoid process during your technique, and this is present in about 20% of the patients. But in cases of suspension and arthroscopic reconstruction, it's also important to address the AC ligament. I will present some of the cases with the hook plate, and this is my experience in about 15 years. So this is a patient with dislocated AC joint type 3, was treated with the hook plate. And this is the approach, very conservatively. You do not dissect, you just try to reduce the AC joint in both planes and repair, as you see, the 3 sutures here of the CC ligament, which has a broad footprint, and then you close all the soft tissue sleeve over the plate. This is another case with dislocated AC joint treated by the hook plate, and the patient post-operatively can early mobilize with very good range without any pain and can go back to his work or to some jogging and very limited types of sports. And then the plate is removed after 4 months without any restriction of movements after removing the plate. He can go directly back to his sports. This is another case in which there is fracture of the lateral third of the clavicle. We do a CT scan to study the displacement, and then we can use the hook plate to reduce and repair the ligaments and close the soft tissue sleeve over the plate. So in conclusion, best results are achieved if there is early management in about 3 weeks, if there is proper choice of the hook plate, if there is reduction in the 2 planes, You should repair the ECZ and the CC ligament, early rehabilitation, and removal of the hardware in 4 months. Thank you very much.
Thank you, Dr. Yasser, for this nice presentation. Now we're going to move to Dr. Muhammad Abdel-Aal, who will give us a talk about post-traumatic acromioclavicular, the endless dilemma.
Bismillah ar-Rahman ar-Rahim. I'm going to discuss the acromioclavicular joint injuries. First of all, I would appreciate my presence with my colleagues in the EGSSA organization. I hope that all the members and attendees are still fresh. First of all, as I said, that acromioclavicular joint injuries is an issue of controversy. And as I say, as we will see in the upcoming slides, that the AC joint injury had a lot of controversy regarding the anatomy, pathophysiology, etc. And so our learning outcome of this issue is a short introduction about the acromioclavicular joint, a few points about the anatomical background and the classifications of injury, and a few words about the tips and tricks in surgical and non-surgical management. Then we will open the discussion about this issue. First of all, and as I said, that there is a lot of controversy regarding the acromioclavicular joint from the point of anatomy or from the point of pathophysiology or intervention, whether surgical or non-surgical. I'm not going to go deep through the anatomic points of the acromioclavicular joint as it had been discussed by many of my colleagues, and it will be discussed later. But just I want to stress on a deep point regarding the anatomical details of the normal strong stabilizers of this joint. And these are the coracoclavicular ligament, the acromioclavicular ligaments, and the capsule of the joint. Regarding the coracoclavicular ligaments, we have the trapezoid and the conoid ligaments, and these are concerned with two types of motion limitation. The trapezoid resists the superior movement of the clavicle, and the conoid resists the superior movement of the clavicle. While the acromioclavicular ligament is concerned with checking the horizontal motion of the acromioclavicular joint. And as you see here, that most of these studies of the pathophysiological studies of acromioclavicular joint depend on the sequential severing of the ligament, and all of them stressed upon the lateral coracoclavicular, the conoid and trapezoid, and nothing mentioned about what is called the medial coracoclavicular ligament. This is this ligament, or what is called the Caldani ligament, medial coracoclavicular ligament, had been discovered and mentioned in 1802 by Professor L.M. Caldani. And then after this, nothing had been mentioned about this ligament, although it has a very great importance from the biomechanical point of view. It was described as a pearlescent yellow bundle hand fan of fibers located at the infraclavicular space, with its apex converging towards the coracoid process and its axis constituting the body of the ligament. A lot of studies concerned with this ligament, but few of them are mostly contradictory. And many articles stated that this organ, this ligament, is had imprecise function, exactly like the appendix. Regarding the biological findings of this ligament, its anatomy is coincident with the histological structure. How its central part formed of parallel collagen fiber bundles, and there is a cartilage cap at its attachment to the coracoid process. And this small diameter of this ligament had been compensated by torsion of its middle third fibers to make it more strong against the tensile strength, make its tensile strength more strong. And this feature shows that it has an adaptation to both the compressive and the shear forces that may be exposed the AC joint to these stresses. What is the function of this medial coracoclavicular ligament? It was considered as the last restrainer of the coracoclavicular space in the absence of the lateral coracoclavicular ligament. How we can consider this? This is a cadaveric study, as you see here. Sorry, this is a cadaveric study. Here, the distance of the coracoclavicular distance is about 15 millimeters. If we sever the lateral coracoclavicular ligament, we'll see that this distance will increase up to 42 millimeters. And by severing the medial coracoclavicular, this distance increased up to 63 millimeters. And this may explore how much it is concerned with the stability of the acromioclavicular joint. Also, it may be notable for difference between type 3A, as we will mention later on, and type 3B injuries. And it is involved in thoracic outlet syndrome and may be severed in type 4 and type 5. We all know the Rockwell classification, who has emphasized that the difference between type 3 and type 5 is the detachment of the muscle. But we can add here that detachment of the muscle, in addition to the severing of Caldani ligament or the medial coracoclavicular ligament, is another factor for type 3 to differentiate between type 3 and type 5. From the clinical point of view, this is possibly hinder the circulage technique. If you want to make a circulage for the coracoclavicular ligament, for the acromioclavicular joint subluxation or dislocation, this ligament may hinder this technique. Also, it has a role in containing the coracoclavicular space in the absence of lateral coracoclavicular ligament. Regarding the mechanism of injury of the acromioclavicular, as mentioned by my colleagues, that the sport injuries constitute very high incidence of this injury. Also, impact on the superior acromion may be one of the causes. Regarding the result, a lot of classifications of the acromioclavicular joint, but the most popular one is the Rockwell classification, who classifies this injury into 6 types. I'm not going deep this classification, but what I want to stress is that this classification depends upon the distant coracoclavicular distance. The more the severity of the injury, the more the increase in the coracoclavicular distance, the distance between the coracoclavicular distance. However, now we better to measure what is called the acromioclavicular distance. What is the acromioclavicular distance? It is a measure between the acromioclavicular, taking and what's called Alexander view, and the acromioclavicular dorsal clavicle definition and a realistic appreciation for the AC joint replacement instead of using the coracoclavicular space as a measure. This is more useful in considering the acromioclavicular joint subluxation, especially in type 5 injury. As regards the decision-making of the treatment, a lot of controversy also had been discussed, either from the conservative point of view or the surgical point of view. There is no enough data which prefer one of these methods over the other. you see here a lot of articles talking about the use of conservative and operative treatments. Many treatment modalities have been discussed regarding AC joint dislocation, ranging from aggressive surgery, whether implanted or non-implanted, including coracoclavicular screws, tension band, K-wires, hooks, plates, to the non-operative management. And there are a lot of articles talking about the non-operative treatment of acromioclavicular, except in few cases we will discuss it later. And we should mention here that the conservative may take a chance for treatment of acromioclavicular joint, except in young patients, sport, and tasks requiring over-shoulder activities, and the type 3B injuries. These should be considered for operative intervention. The real indication for surgery, as recommended by Professor Rockwell, should put in consideration the age of the patient, meaning that the younger the age, the more preference toward the surgery, the expectation of the patient, and also sporting activities. When to do surgery? This is a very important question. Should we do surgery for only the young patient? No, a lot of controversy also have been mentioned, whether to do surgery or to do conservative, and whether to do acute or chronic. And we mean by acute or chronic meaning to interfere early or to interfere late. However, the ease of surgical intervention and the better results of the surgical interventions make the tendency toward the aggressive interference to be more and more. Whether to do repair or to reconstruct still also a point of controversy, as reconstruction makes more return to the normal anatomy, restoring more the biomechanics of the ligament and the joint, and the central restoration of the function. However, many articles talk about the early intervention as being having high constant score and early restoration of the anatomical reduction and less complication and the more satisfaction for the patient. Should we respect the distal end of clavicle as many surgical intervention mentioned? This is a point of controversy. A lot of articles talk about the non-preference to resect the distal end of clavicle as a measure for treating the acromioclavicular joint subluxation. However, this procedure of excision had a lot of shortcomings, including technical errors, the scar complications, and calcifications. Also, repairing the coracoclavicular, should we repair it or not? To repair it and leave it as it is. There is a comprehensive article talking about repair or reconstruct the coracoclavicular ligament, and it should be considered to restore the kinematics of the acromioclavicular joint regarding the mechanical function, it has the proprioceptive function, and regarding the stability of the joint. So it is preferable to repair the coracoclavicular and search for it and repair it. Should we look for it? Yes. You should look for, especially in acute injuries, you should look for where is the ligament. And many articles stated that it doesn't heal. No, it heals. The ligament heals. How does it heal as other ligaments? Yes, there are a lot of evidence. And the MRI give us an idea that this ligament will heal, and the repairing of the ligament is mandatory. Regarding the implantable material, should we use non-absorbable or absorbable? All these materials show some complication. The non-absorbable make resorption of bone around these materials, and the non-absorbable materials may be broken, and it requires a second operation to remove it. The use of hooked plate, which is many articles stated that it is not wise, especially in acute cases, and there is a liability for infection and osteolosis of bone. Another operation is mandatory to use, so it is used in specific cases of reconstruction. Regarding the tightrope, yes, it would have been used especially by those who use the arthroscopy, but it is still expensive and it has a learning curve, and it is not adequate procedure to stabilize the AC joint because it doesn't repair the acromioclavicular ligament or contribute to anteroposterior stability. Transosseous suturing technique also, this is a technique. However, there are many articles stated that the transcoracoid single clavicular tunnel technique was not reliable to approach coracoclavicular ligament reconstruction. And we noticed the high percentage of radiographic redisplacement mode occur by this technique. Lamberman in 2013 comparing the results between three types on three techniques of using implantable material. From the biomechanical point of view, the performance of the cerclage is more than the tightrope, and the cerclage gives more physiologic stabilization. To do surgery by open technique or arthroscopy is still a sort of controversy, and the open and arthroscopy, both of them give good results. But the arthroscopic technique in well-mastering the technique in trained hand may be preferable. However, this is a study stated that in 116 cases in 1 year, 48 cases had still persistent subluxation and 22% had the complications. And loss of reduction occurred in 33% of cases, and totally 44% of complications occurred in cases using the arthroscopic technique. So we can say that the best technique for treating acromioclavicular joint is the technique you master. Take-home message: AC joint should be fully estimated, and the early treatment should be considered. Age, occupation, and expectation of patient should be considered. Repair of coracoclavicular ligament, this is an important point, should be considered, and the use of absorbable suture instead of metallic implant should be considered. And to do it open or arthroscopy, as you said, the best technique is the technique you master. Thank you very much.
Thank you very much, Dr. Mohammed Abdelal, for this nice presentation and giving us an idea about the medial CC ligament. I think we're going to have many questions for you at the end of this webinar. Now we're going to move to Dr. Ashraf Muharram, who will give us a talk about scapular fractures.
مساء الخير عليكم جميعا. أنا اسمي أشرف محرم. أنا أستاذ جراحة عظام في الطب القصر العيني and an upper limb and a consultant and microsurgeon. I'm happy to be with you tonight. I apologize I cannot be online because I'm not in Egypt currently. فقررت أن أسجل هذه المحاضرة عشان أقدر أشارككم وبشكر الجمعية والدكتور ياسر الصفوري على كريم دعوته. Let's kick off with the presentation. Scapular fractures. This is my neighbor. He's 35 years old, and he had a motor car accident and developed this isolated injury, which is, by the way, very rare to be isolated. What do you think? How should I treat him? Should I conserve? Should I operate? I hope by the end of this lecture, I'll tell you how to recognize and evaluate scapular fractures, classify them, and identify the indications of surgery, as well as the operative approaches and the expected outcome. It's not common. It's less than 1% of all broken bones and about 3 to 5% of shoulder girdle fractures. And why is that? Because it's a really thin and elastic bone, which freely moves over the thoracic cage. So it's difficult to injure it. It is usually injured in high energy trauma, and that's why 90% of these patients have associated injuries. The mechanism is usually a direct blow, while indirect blows are uncommon, maybe fall on an outstretched hand with the head being pushed into the glenoid to cause a fracture of the glenoid or a fracture dislocation of the shoulder with a fractured glenoid. While most commonly it's a direct blow from high energy trauma and this is associated with other fractures and other injuries in 70 to 100% of these patients. Most common injuries, fractures are ribs, clavicle, as well as skull, while most common injuries are head injuries, neurological injuries, as well as pneumothorax and pulmonary contusions, ruptures of the spleen, and the renal injuries. Clinical examination is very important to detect associated neurovascular status, injuries, and associated fractures and other injuries as well. X-rays, we usually need a true AP and a Y view. It's not common or easy to have an axillary view in these patients with scapular fractures. CT scans are standard with 3D reconstruction to evaluate these injuries. Traditionally, these fractures are minimally displaced and are treated non-operatively in about 90% of these scapular fractures. And this patient had an extra-articular fracture of the body of the scapula, and this is 6 weeks post-injury. She has almost full range of motion. That's why 90% of these fractures are non or minimally displaced and show good results. However, since all 30 years since Nordqvist published a paper saying that out of 48 patients, he followed up 20 patients had malunions of the scapula, and 42% had residual symptoms in the manner of pain, functional deficits, decreased range of motion, and strength, as well as shoulder muscle imbalance. We know that malunited fractures of the scapula alters the shoulder girdle function, malalignment and arthrosis, dysfunction of the rotator cuff, impingement type of pain, as well as scapulothoracic dyskinesia. So, although traditionally we treat these patients non-operatively, more and more studies document the advantages of operative treatment, especially in patients who are indicated for surgery. And this is the main value of, I hope, this lecture, to point out which patients are indicated for surgery. The best classification out there and the most comprehensive is the AOPA classification, which was done by the AO Foundation and the American Orthopedic Trauma Association, and was published in the journal Elbow Journal in 2013 by my dear friends Martin Yeager and Simon Lambert and quite a few other consultants as well. They divided the scapula into 4 components: the fossa, which is the articular fragment, the glenoid and its neck, the body, and the processes, which is the acromion and the coracoid. And they added the letter S to evaluate the lateral scapular suspension system. So if it involves the body, it's a B. If the fossas involved, we talk about an F fracture. If both, it's an FB fracture. If the process of fractures, it's an FBP or a BP. And we use S to designate the lateral scapular suspension system. There's 2 levels of classification: the basic one for rapid and simplified documentation, while there's an advanced system to put much more details into these injuries. Body fractures, B, are either extra-articular fractures with no glenoid involvement, or they involve the glenoid. If it's a B1, it's a simple fracture line that involves 2 breaks into 2 or less breaks into the body, while more than 2 breaks is defined as a complex involvement. And we usually, I don't think you see my cursor there, and we usually use, look where it comes out, and this would be an SL B1 fracture, while this would be SML body fracture. What about the fossa fractures? The fossa fractures either involved or extra-articular, involve the neck, and they're FO or an F1, which is a simple articular fracture, and F2 is a multifragmentary articular fracture. Process either P0 is a coracoid fracture, P2 is a acromial fracture, while P2 is a coracoid and acromial fracture, while the S0, there's no involvement of the lateral scapular suspension system, while S1 is an incomplete failure of that system, and S2 is a complete failure of the system. What is the indications of surgical treatment? In a landmark paper by my dear friend Peter Cole in 2012, he pointed out three major points. One that involves the body, which is angulation of the body. You can see in the middle picture there, or a glenopolar angle, which represents the rotation of the glenoid around the body, or the medial or lateral displacement of the glenoid. So let's see the importance of each of those. Which typically types of fractures need surgery? Those involving the glenoid fossa, involving articular fractures, those involving the neck fractures, and those involving ipsilateral fractures of the clavicle. You can see that these represent about 90% of the indications, 85% of the indications in the paper in the systematic review published by Landry in 2008. Intra-articular fractures that glenoid represent 10% of these fractures. They are usually meaning displaced and managed conservatively, but if they're displaced or associated with scapular injury, they are usually, with shoulder instability, they are usually fixed. The step of more than 2 millimeters is considered an indication of surgery. While glenoid neck fractures are most commonly as well managed conservatively, the indications of fixation include medialization of the glenoid or rotational angulation of the glenoid. How do you measure medialization? Through measuring the displacement of the lateral border. This medialization represents telescoping or shortening of the length or the width of the scapula, to be more accurate, and this is associated with muscular or rotator cuff dysfunction. If it's more than, if the medialization is more than 10 to 20 millimeters, then we probably will have dysfunction of the muscles around the shoulder, especially the rotator cuff, and this needs fixation. What about glenoid neck rotation or glenoid alignment? This is measured by the glenopolar angle, which is from the highest point of the most cranial point of the glenoid to the tip of the scapula and one parallel to the articular surface of the glenoid. This case is displaced and there's 18-degree angulation, and we know that there's a correlation of poor outcome with glenopolar angle less than 20 degrees, published in many articles. So restoration of the glenopolar angle is one of the goals of operative management of the glenoid neck fractures. You can see it here, it's been restored from 18 to 32 degrees. What about extra-articular body angulation? More than 30 degrees is associated with scapular dyskinesia and is considered an indication of surgery. And definitely more than 45 degrees is an absolute indication of surgery. How do we operate on these patients surgically? We either go ventrally to do a Judeo Approach, which was very rarely used in coracoid fractures, anterior limb fractures, and acromial fractures, but most commonly we use a posterior approach, which gives us a very good access to the glenoid, the neck, and the body of the scapula. Classically, we use the Judeo Approach, which is a big L-shaped incision over the back of the scapula, but now more commonly we're using a Brodsky approach, which is a modification of Judeo, in which we use a more vertical line of incision in one along the posterior aspect of the scapula parallel to the medial border. What about the Judeo approach? It is the classical approach. It uses an internervous plane between the infraspinatus and the teres minor. The infraspinatus is elevated off the back of the scapula and being based on the scapulo, on the suprascapular nerve there. we elevate it to expose the whole body, and we rotate the infraspinatus superiorly based on the suprascapular nerve, which is his nerve supply. Well, the Brodsky approach, again, a longitudinal incision over the lateral aspect of the shoulder, and we develop 3 internervous planes. We do not detach or elevate the infraspinatus off the back of the scapula. We use 3 windows to expose all the parts of the scapula. And the more you have experience, the more you get used to the Brodsky approach, the more you won't need the detachment or the elevation of the infraspinatus. Remember my dear neighbor? So what do you think? Is he indicated for surgery? Well, yes, he has got medialization more than 2 millimeters, and his glenopolar angle is less than 18 degrees. So he's indicated for surgery. We go into the operating room, we do Judeo Approach, we elevate, and we see the fracture and reduce it after elevating the infraspinatus anterior minor, the plane between those. Where do we put our plates? We could look at against the scapula, against the light. You find that the body is very thin, except at the glenoid area, the lateral border of the scapula, the spine of the scapula, and medial border of the scapula is where we usually can put our fixation. We go and we put 2 plates, one on the medial border and going up to the spine of the scapula, and on the lateral border, and restore the glenopolar angle and the medialization. 83% of patients going open reduction internal fixation of their scapula represent good to excellent results. And the post-operative complication most commonly is prominent or symptomatic hardware, some joint stiffness, residual pain or weakness, and sometimes infection. So my take-home message to you guys is beware of high incidence of associated injuries. You have to put this in mind when you see a fractured scapula. And conservative treatment is still the mainstay. However, operative treatment can yield excellent results and low complication rate when indicated in articular step-off, medial displacement more than 2 centimeters, glenopolar angle of less than 20 degrees, as well as a floating shoulder. These are considered to be operative indications. Stabilization with plates and screws through a posterior approach is the most commonly accepted open reduction internal fixation method. Thank you very much. I hope this was useful, and I hope I can catch up with questions if I'm able to log on to the internet in person when I arrive to Cairo. Thank you very much.
Thank you, Dr. Ashraf, for your presentation. And now we're going to move to Dr. Sharif El-Ghamri, who's going to give us a talk about the arthroscopic treatment of glenoid fractures. Dr. Sharif.
Yes, hi. Let's start at that. Yes, next. I would like to acknowledge my co-author, Professor Dr. Bassem Fleger. Today I'm going to talk about the glenoids. And fractures of the glenoids are often seen in association with the various shoulder instability patterns as a bony banquet. Next. Many classifications of the glenoid fractures based on plain films, radiology, or using the CT as the Edinburgh classification in 1984, the Euler classification, and the Orthopedic Trauma Association classification were published. Next. The most common classification used is the Edinburgh, the 6 fracture types classification in 1984. Next. Next. اللي قبلها بتاعتي. controversy exists over management of the glenoid fracture. The treatment depends on the instability, the degree of displacement, the fracture gap, the fragment size according to Fresh and Ayal 2017. Yeager and Lambert in 2013 stated that many fractures are small and minimally displaced and can receive conservative therapy. Also, Van Oostveen in 2014 stated that surgical treatment is less favorable and only about 10% indicate the need for surgery. Avulsion fractures of less than 5 millimeter that are stable require conservative with immobilization. Next. Next. Yes. Arthroscopic surgery has made considerable advances in treating anterior glenoid rim fractures with a reduction in complications and reoperation rates. Surgeons often use the arthroscopic approach in combination with percutaneous screw fixation. Next. Yes. According to Fresh and Larson in 2017. Next. Arthroscopic screw fixation of the glenoid fragment is used, but the disadvantage is that it is only possible with large fragments, and it may be damaged the cartilage. Arthroscopic repair by anchor suture is reported by using 2 anchors, one in front and one in the back of the fracture, to fix it to the glenoids. Next. Our road plan of treating anterior glenoid rim fracture is based on classification of the fracture into acute fracture with 3 types, non-displaced, displaced without labrum tear, or displaced with labrum tear, and all fractures with 3 types, non-displaced, non-united, displaced medially non-united, and displaced medially united. Usually, all glenoid fractures with recurrent dislocation includes redundancy and enlargement of the capsule. Next. We use 3 different techniques of arthroscopic fixation depending on the type of the fracture. The upward labrum shift suture fixation, the transosseous suture fixation, and the inferior capsular shift fragment fixation. Next. These are the instruments used, which are the suture passing device, a chop needle catcher, and the suture pulling device. The chop needle puller and the PS wire system, including a K wire, and the guide and the penetrating suture wire. Next. Next. Hello. This is the standard of the arthroscopic position in the sitting position with the arm hanging. In case of acute fracture of the anterior glenoid rim with intact labrum, we pull the intact labrum with an absorbable suture upwards to place the fragment in its anatomical place and fix it there. And this is done by using the chop needle suture placing system. The shoulder is then immobilized in a sling for 3 to 4 weeks. Next. In case of old fracture with recurrent dislocation, there's always a redundancy of the anterior capsule, as seen on the left side. So by doing an arthroscopic inferior capsular shift, the shifted inferior and middle glenohumeral ligaments will pull the fragment and fix it to its place. Now, this is done after making a bleeding surface on the glenoid and the bone fragment. The shoulder is then immobilized for 6 weeks. I'm going to show this in the video soon. Next. An acute fracture with torn labrum has still the bleeding surface. Now, in this case, we do a transosseous suture fixation using the PS wire suturing system. Next. Next. I'm sorry about the delay, it's because of the internet. The suture is passed through the glenoid and around the bone fragment and fixed to its place by tying the suture. The PS suture wire is passed I'm sorry again about the internet. Now drilling the hole. Next. The suture is then tied with a sliding knot to fix the fragment in place. Next. As we see here. Next. Now this is the video, and start. This video shows an old displaced malunited anterior glenoid rim fracture. Here we can see the osteotome is done to release the malunited fragments. Then a bleeding surface is created. And then we try to push the fragment to reduce it. And this is followed by passing the suture through the glenoid and the fragment, and finally will be tied. This is the suture. And this is the knot. Next. We do a post-operative management will be by immobilizing in a cast or special brace in 50 degrees internal rotation and 10 degrees abduction for 4 to 6 weeks. But in cases of treatment or with arthroscopic inferior capsular shifts for old fracture with anterior capsular redundancy, it will be put in a neutral rotation to preserve the anatomical length of the capsule and ligament. Next. So in summary, the treatment protocol we use is for acute non-displaced fracture is conservative. For acute displaced fracture without labrum tear, we do arthroscopic upward labrum shift suture fixation, and for the acute displaced with labrum teeth, a transosseous suture fixation. Next. For the old non-displaced fracture causing pain, we fix the fragment with transosseous suture after abrasion of the surfaces. If the fragment is displaced, either malunited or non-united, with a history of recurrent dislocation, an arthroscopic inferior capsular shift with fragment fixation is done. Next. Thank you.
Thank you, Dr. Sharif, for your nice presentation.
And sorry about the internet, it was terrible, I know.
No problem, no problem. And now we're going to move to Dr. Simon Lambert, who is going to give us a talk about evaluation and management of clavicular fractures. You may proceed, Dr. Simon.
Thank you very much indeed. Let me show you my screen. There we go. Can I confirm that you can see and read my screen, please?
Yes, we do.
Lovely. Thank you very much. And thank you once again for your kind invitation to join you. I've listened to the previous speakers with great interest, and in particular, the presentation on the medial coracoclavicular ligament, which is a very interesting subject and close to my heart. So I'd be delighted to join in a discussion about that particular bit of anatomy, which I agree is not that well appreciated, perhaps, and very probably quite important. But we're here to talk about clavicle fractures. When I started thinking about clavicle fractures a bit more deeply, largely in my role to do with the upper extremity expert group and trying to think about how we could improve clavicular plate systems, it was always a good idea to go right back to the literature and to the issues that matter to our patients. And in order to organize my thoughts, I created this matrix, this table, where things that matter to patients, like the overall function of their shoulder girdle, how it looks, how it feels in terms of irritability of the brachial plexus, and whether it is malunited or non-united and symptomatic in both cases. If I have treatment, what is the complication rate? And if there are complications, do I have to have another operation? And if I have to have another operation, am I simply going to be facing persistent pain? So what's the likelihood that I'm going to be dissatisfied with my clavicle fracture if I have an operation or not? And so we started to draw together some of these ideas. And from literature, we get some impressions about what outcomes are truly the case after non-operative management. We see that about half of patients are worried about how it looks. About a third of patients are concerned about some diminution in overall shoulder girdle function. And another third, that's a high percentage, will have symptoms if you ask them about brachial plexus irritability, particularly of the lower cord, the lower trunk and medial cord, giving symptoms into the forearm and the ulnar border of the hand. We also know that non-union can be symptomatic, and interestingly, malunion far less symptomatic, which is intriguing if you discount malunion associated with brachial plexus irritability or subclavian venous compression. Overall, the complication rate of non-surgical management of clavicular fractures is roughly 4 out of 10 patients will have trouble. But of course, they don't have the complications of surgery. So if you look at the people who've had surgery, at the time I wrote this, which was 3.5 years ago, we knew that patients with more anatomical shaped clavicles had better dash scores and better constant scores. But if you remove the factor of non-union from the non-operative group, then operative and non-operative treatment, according to Chris Robinson in Edinburgh, resulted in similar functional outcomes. I think that has now been challenged by our knowledge derived from randomized controlled trials, one of which was conducted by my colleague Philip Ahrens in North London, which has pretty clearly shown that surgical treatment of a clavicular shaft fracture will result in a more rapid return to work, a more rapid rate of union, and an increased rate of completion of union. And of course, also a very much lower malunion rate. So our knowledge about the outcomes of clavicular fracture relative to non-surgical treatment is now that operative management probably offers an advantage in the majority of people. It is interesting that in the Edinburgh study of midshaft clavicle fractures with what was called wide displacement, that is more than 2 centimeters of fragmentary displacement, or multifragmentary comminuted fractures, particularly with angulation, shortening, and, as I say, comminution, was a 1/5 of patients had a non-union, which was symptomatic. Now, I should tell you, if you don't know already, and if you haven't visited Edinburgh, that quite a number of people in Edinburgh are smokers, and a fair number of people drink alcohol to excess. And both factors might be confounding factors in that high rate of symptomatic non-union. However, another study from Michael McKee and Emil Shemich's unit in Toronto have shown a complication rate of operative treatment amounting to something like 1/5 of patients, related to the accuracy of reduction and fixation. And we'll come to this in a short while, but that starts to build in the issue of surgical competence. Why do people with non-operative treatment become dissatisfied with their outcome? Well, it's to do with the shape of the shoulder and to do with the irritability of the brachial plexus. When the scapular position is displaced or abnormal at rest and during movement, and we've heard about the importance of scapular posture and movement with acromioclavicular joint dysfunction. Well, what does that mean for us? It means that non-union in non-operatively treated fractures generates most of the non-operative problems with brachial plexus irritation. And the fact that there is a lump at the end in the clavicle itself, or an abnormal scapular position leading to abnormal shape of the forequarter, is fundamentally linked to the decrease in overall function, not just an appearance problem. The brachial plexus is, as you know very well, intimately related to the upper surface and lateral border of the first rib, and the clavicle is bound to the first rib anteriorly through the very strong rhomboidal costoclavicular ligament, behind which the subclavian vein passes. And therefore, the relation between the medial clavicle and the first rib is fairly immutable. Where the clavicle goes, so does the first rib. Now, the first rib doesn't move very much, as you know. It goes as a bucket handle up and down. So the medial end of the clavicle essentially goes up and down with the first rib. Not so the lateral part of the clavicle if it's fractured from the medial part, and we'll come back to that. Malunion has consequences on the retroclavicular and infraclavicular space, and a study that we're doing at the AO Research Institute in Davos is trying to describe that change in the volume and shape of the retroclavicular and infraclavicular space during clavicular, as a result of clavicular malunion. We're partway through that project at the moment, but it's looking fascinating to see how, in the first place, the intact clavicle relates to the first rib, and we expect to be able to demonstrate some rather useful morphometry in relation to displaced clavicular fracture simulation. Why would non-union occur in the clavicle? Well, we'll talk about that in a little while, but it's to do, of course, with perfusion. Periosteal damage is the key because endosteal perfusion of the clavicle is relatively poor in the adult. There's a lot of information about the economic cost of operative treatment of most things because economists and hospital administrators want to know why we're spending so much money. But there's not much knowledge about the economic cost of non-operative treatment, except that we now know that the return to work is slower in those with non-operative treatment by several weeks. And that must have an economic cost both to the individual and society. Well, we can make these assessments of current knowledge of clavicular fractures, but by and large, the literature allows us to say some very broad things. First of all, that in non-surgical treatment, overall, malunion and its associated symptoms of brachial plexus irritability and subclavian venous congestion and scapular postural abnormality is present in about 1 in 3 people with non-operative management of a shaft fracture. For non-union with symptoms, the incidence in non-operative management is roughly 4 in 10, and overall a complication rate for non-operative management is something like 1 in 2 if we ask for the symptoms. What can we do to change that? Well, first of all, we want to be able to predict which patients with a clavicular fracture might go to a non-union if we're choosing to do non-operative management. The features of the fracture that generate periosteal damage and therefore non-union include displacement, of course, not just translation of 1.5 to 2 centimeters, but also rotation, which is inevitable where the lateral aspect of the clavicle rotates ventrally under the weight of the arm, thus rotating the scapula dorsally and laterally. It also leads to the idea that restoration of the clavicular shape is not only about restoring biomechanics, but also allowing stable fracture zone reperfusion. But we also know that the plates that we've used in the past are not perfect. There's a lot of hardware out there which is not anatomically correct, hasn't been thought through very well, and does not fit terribly well, which leads to reluctance to use it. And the main feature of clavicular fractures, which is the position and movement of the scapula, is extremely difficult to assess. We don't have a very good scapular functional assessment mechanism or score. So we're not really able to measure exactly what we need to. We mentioned the DASH score, which is probably the closest and most useful. The constant score is much more about rotator cuff function. So Operative intervention for me is about the position of the acromion, i.e. the glenoid. In other words, the shape, length, and alignment of the clavicle determine where the center of rotation of the glenohumeral joint is, and that's what we're aiming to restore. It's also about restoring this concept of the retroclavicular space and reducing the risk of poor perfusion of the fracture and therefore non-union or failure to unite in a good position. Here's an idea about the subclavius, and this relates to the lovely talk about the acromioclavicular joint separation, because that medial coracoclavicular ligament is an extension of the inferior tendon of the inferior border of the subclavius muscle, shown closest to the clavicle. Now, it's a muscle that's one of my favorite in the shoulder, the other being teres major for various reasons, but this one's interesting because it's the only muscle in the shoulder that's got its own nerve supply. And therefore, in one sense, in an evolutionary sense, it was really rather important. And we can talk about that in discussion if you like. But the importance of this, of course, is that if you fracture the clavicle and therefore allow shortening or rather relative lengthening of that muscle, its action on the clavicle cannot be as useful as it was before. And its action is to decelerate the lateral end of the clavicle, as it were, as an antagonist to the trapezius. So the trapezius both bridges the acromioclavicular joint, though stabilizing it and contributing to stability, but also pulls, of course, the lateral end of the clavicle upwards and backwards, and that is antagonized through pectoralis minor and the weight of the arm and subclavius. If you disable subclavius by shortening the clavicle, then the effect of deceleration of the scapula is not met. And scapular movement is never normal in a non-union or malunion of the clavicle. The clavicle, as you undoubtedly know, has an interesting embryological origin, and its perfusion or its blood flow is related to the embryology. So it's basically the medial half and the lateral half have different blood supplies. From the point of view of the clavicle, the major part is periosteal, and you know that that is related to the insertion of pectoralis major and the deltoid. So if we strip these muscles during the course of dissection, we risk damaging periosteal perfusion if that is still present, which means that for me, the antero-inferior clavicular approach and plate do not personally make too much sense. The endosteal blood supply is flimsy, but mainly goes into the medial part. So if you look at a healing clavicular fracture, you'll see callus from the medial fragments and not from the lateral side. So a non-union will be generated more in the more lateral clavicle fracture, which is more of a challenge because the lateral clavicle has, of course, the curious curves. So if we're going to do operative intervention, we've got to be clear that we're going to minimize the risk of complications, which are largely about iatropathic neural injury and iatropathic vascular injury. There are case reports and frightening literature about the potential injury by overpenetration of the distal cortex when drilling and putting in screws to damage the subclavian vein. And indeed, people have died. But that's to do, I would suggest, with hardware and how it's used. That's to do, of course, with surgical technique. And that's where courses like yours and the AO courses teach safe technique with safe use of the implants. So how does internal fixation for displaced multifragmentary midshaft fractures give better patient-related outcomes? Well, when we're thinking about that, you and I in the clinic are unconsciously looking at the space behind and around the clavicle in terms of the plexus and veins and the suspension of the scapula. We then look for imaging to understand or predict the functional outcome with or without intervention. And rather than rely upon classifications to tell us which particular clavicle fracture to fix, my sense is that we should be looking at the anatomy and pathoanatomy of these difficult to assess spaces and the concept of scapular suspension, for which CT scans are probably the best option. Can we reduce the complication rates of operative intervention? And please remember this these ideas were forming in response to all these challenges in about 4 years ago. And since then, it's been our privilege to work in the AO and with Dupuis synthase to generate a new generation of clavicular plates in order to try to reduce the complication. We have used a number of technologies and a number of epidemiological studies, morphological studies, to look at the clavicle shape. And you will see a video now, I hope, illustrating this.
Using the process of cylindrical...
You might have to turn up your volumes.
Lucas and Hans Rudino.
Oh, excuse me. Let's do that again. We looked at a number of clavicle models. First of all,
Lucas and Hans Rudinoza produced 3D models of the...
If you can't hear that, I'll talk over it. We looked at three-dimensional models of 100 clavicles, and we made models of the, as it were, the greatest, largest clavicles, the smallest clavicles, and the middle-sized clavicles. And we decided we would describe what we would imagine to be the implant-preferred pathway for these clavicles. That is a pathway for a plate that did not damage soft tissues as much as most clavicle plates do. And for those, we then generated a series of curves with the average over the population of each clavicle, generating a linear model, which we called the implant-preferred pathway, the so-called region of interest from a computational point of view. And then we discovered some very interesting things. If you map all the medial ends of the clavicle, one on top of the other, so they match at the medial end, there is some overlap and some similarity in the medial curvature, but of course the lateral curve is different. It looks, of course, different. It's a different shape, a different curvature. And so if we start fixing a clavicle fracture medially, we have the problem of contouring a plate laterally or designing a plate to fit laterally. If you map or match the middle thirds of these lines, you get closer matching laterally and shortness of the similar medial anticurve with some differences in length. But here's the fascinating thing. If you overlap those models laterally, first of all, you see that the curvature of small, medium, and large clavicles is the same. And there is a very close match in the anticurve with simple shortening. So length in the clavicle is related to the medial anticurve, and the lateral retrocurve could be said to be almost, from a statistical point of view, similar, whether it's a small, medium, or large clavicle. Well, that's a very different concept to what we think of as the clavicle. Of course, this doesn't account for surface morphology, and we've done some more about that more recently.
fewer.
But that gave us some insight into how to think about internal fixation of clavicle fractures, the implant preferred pathway. We can draw some conclusions and then have a discussion. Clavicle fractures were thought to be benign, but they're not. Non-operative management does result in a high instance of unsatisfactory outcomes. But our patients' concerns are not really very well measured by current patient-related outcome measures or scores. However, if we get clavicles healing as close to anatomic as possible, there is a drift towards better outcomes, and that is now being established through randomized controlled studies. If we do operate, most complications are related to hardware failure, so we've got to get the hardware right, or hardware, abusive hardware, i.e. the vascular and neuro complications. So better hardware design might overcome many of the issues that prevented us from being comfortable with internal fixation of clavicular fractures. And we believe that we're getting there with our current design of clavicular fracture plates, which are just about to be released for general use. So thank you so much for your overall attention to that. I'll now stop sharing my screen and we're back to the chairman. Thank you very much indeed, Ahmed.
Thank you very much, Dr. Simon. That was a very interesting, actually seeing the design of the plate and the models that you did, the 3D models. I think we come to the discussion right now, and we have a couple of questions for Dr. Yasser Sapuri. Dr. Yasser, about the hook plate. Do you use them frequently? How often do you use the hook plate?
It's the same indication for fixations.
Can you raise your the voice, please?
Okay. Can you hear me better now?
Yeah.
So if there's an indication for treating dislocated AC joint like type 3B or 4-6, then you should decide what type of device you're going to use. So if I decide to do surgery, what I use for about a long period of time, about 15 years, the hook plate. But it's not about using the plate more than using it properly. I mean, it should have a good approach, and you should locate the ligaments. You should reduce the AC joint in a proper vertical and horizontal orientation. You should look for the ligaments, and you should close the sleeve, the soft tissue sleeve, over the clavicle. And sometimes you can put a suture mark at the area where you just remove the hook. So when you're going to remove the hook after 4 months, you stop. Even if your assistant is going to do the surgery, he stops at the suture material where is the beginning of the AC joint. Then you remove the hook plate as one piece like this. So it's very ideal situation for athletes because they are very strong people and they are very strong muscles. So they can do the surgery and they can early mobilize. And when you remove the plate, you do not need except 3-4 days of the wound and they go back to the sport.
So you prefer using the hook plate for most of the athletes or those who have those like manual workers? Do you prefer to use the hook plates over other methods of treatment?
Because I find them suitable for the very strong and body-built athletes. You're not worried about any other displacement, and you can early mobilize. They can go back to some jogging, or if he works and goes to his job, then he doesn't have this type of immobilization. The only disadvantage is removal of the plate after 4 months. But when you talk to the patient, he says, okay, maybe the first few weeks, if I do the other type of surgery, I'll be immobilized. I'll make benefit of this time in mobilization. No problem for removing a plate after 4 months, as long as it's a minimally invasive surgery.
So you routinely remove the plates after 4 months, right?
Yes. But there are some patients who came after 4 months, 6 months, even more than this, and I removed the plates, and I did not find a great difference in the period of removal of plate. But I'm always worried that they maybe have a fracture, or it may be causing a type of later on of arthrosis or lysis. So I always recommend removing the plate after 4 months.
Okay. Do you deal with the AC joint? I mean, do you routinely do AC resection, or do you just?
I'm 40 years old. I should debride the joint, look for the cartilage, try to remove it. I put a dissector inside the joint and flip out the soft tissue and the capsule. Then I close the soft tissue after putting the plate in one layer, close the AC joint and the muscles all together. As I told you, I stop and put a suture at the beginning of the AC joint, so that when you remove your plate, you do not interrupt at all this part, beginning from the suture until the tip of the acromion.
Okay, perfect. Okay, my question to Dr. Mohammed Abdelal now. Do you really repair the CC ligaments? Do you find that the CC ligaments, do you really, in acute dislocation?
Yes. In acute cases, I always search for it, and I tried hardly to repair it as much as I can. Nowadays, I'm doing a technique. I'll publish it within 3 months. I make a reconstruction through the conjoint tendon, taking the lateral part of the conjoint tendon and rotating around it itself. And during this technique, I insist to find the coracoclavicular ligament and repair it as much as I can.
Okay. So, because most of the time when I go inside, if I do open, right now I'm not doing it open in acute cases. I just do it arthroscopically. But back in time when I do it open, I identify the ligament. But I find it's very difficult to do suturing together. Sometimes it's just evasive from the.
It is friable tissue, but it is yes.
Okay. How do you define late? You said in early cases and late cases of AC joints. Why? How many weeks do we say it's a late?
Dr. Yasser mentions that from 2 to 3 weeks. We said early for the 2 to 3 weeks interference as an early interference. More than 3 weeks, I think it is late, and reconstruction is a must.
Okay. And what's the difference between type 3A and 3B? Because I had several questions.
3A and type 3B.
Yeah.
Yes, type 3A and type 3B, this term begin to be more evident after we said and we talk about the Caldani ligament. The only difference between these two types are the distance. As I show in the cadaveric study, cutting the medial coracoclavicular ligament increase the distance from 42 millimeter to 62 millimeters. So the increased distance, not the coracoclavicular, but the acromioclavicular distance, this is the only difference between type 3A and type 3B, is the increase in the distance we mentioned in the talk.
And when you do it open, you can identify the medial coracoclavicular ligament that you mentioned.
In most of the cases, I tried hardly to find it as much as I can, but sometimes I fail to find it.
Okay, thank you very much. My question to Dr. Sharif Al-Ghamri, as regard the glenoid fracture, when you treat them arthroscopically, do you use screws for fixation? If you have a bigger fragment, do you use screws for fixing this big fragment, or you just do the same technique with the sutures? Dr. Sharif, are you with us? Dr. Sharif?
Dr. Ahmed, do you mean screws, cortical screws or cancellous screws, conventional screws of the internal fixation? Do you mean that?
Yeah, I mean for Dr. Sharif Al-Ghamri, because about his lecture, the arthroscopic treatment of glenoid fracture. So I would just ask him if he's ever using screws for fixing fragments, or he's using also the sutures. So I think we're going to move to Dr. Simon Lambert because Dr. Sharif has a problem with the internet. So from your lecture, I couldn't recognize exactly how often do you fix Cyclabicar fracture. I mean, I got lost for a moment. When exactly, how often do you fix Cyclabicar fracture after all what you said now?
I'm afraid the answer might, let's say, make it difficult for people. I fix every clavicular fracture.
Wow, fix every clavicular fracture.
Well, do you know, it's one of those funny things, because the more I understand about clavicular biomechanics and scapular posture and its relation to the first rib, and the more I understand the literature and the more the literature converges on reasonable ways of assessing function, the better we're able to understand how decrement of function matters. Mm-hmm. And I do acknowledge that most of my work is tertiary referrals. I see the problems of malunion and non-union, and they are considerable and might have been avoided had the decision to undertake proper internal fixation in the beginning had not occurred. That's assuming that I'm not creating a complication rate by operating. I think that's partly to do with hardware and partly to do with experience, but I have a low threshold to clavicular fracture fixation.
Mm-hmm. Okay, and do you routinely remove the implant?
Not routinely, no. I've got several gentlemen with long-term clavicular plates in situ, but they are gentlemen with big muscles and good, hard, robust skin. In many of the smaller, and particularly the ladies, they do want their hardware removed for sure.
Okay, you mentioned in your lecture the CT, and it gives you a better evaluation of the fracture and the orientation of the fracture. So do you routinely do CT for clavicular fractures?
No, I don't. I do CT for malunion and non-union work, of course. But my problem with CT, of course, is that you're lying on your back when you're doing your CT. So your scapulae are fixed by virtue of your posture in the CT scanner. So we get a different view of the clavicle displacement on CT than when the patient is sitting or standing in front of us. And it's the sitting or standing patient that actually one wants to evaluate, not the CT. So I don't get CT for all my acute fractures because it doesn't help me make that clinical decision. That's made on the basis of clinical exam and what the patient tells me. CT I do use for evaluating length and malalignment when I'm going to correct or do osteotomy or lengthening of a short clavicle with distraction. So for specific cases, yes, CT is good. I also use CT or MR with angiography if I'm worried about the relationship of the subclavian system to the malunion if I'm coming close to an osteotomy. So, but not in routine acute fractures, no.
Okay. And what type of plate do you prefer to use in the anatomical plates or what type, or the Rico plate?
Well, if the fracture configuration is a stable one once it's reduced, so it's a type A or maybe a type B fracture. In other words, when you've got the fracture together there is some intrinsic fracture stability, then for reliable patients, I might use a reconstruction plate, might do. But on the whole, I'm using an LCP, which I reshape, because the current so-called contoured anatomic plates are really not accurate. That's what was the motivation for developing this next generation clavicular plate, which we're just releasing from the AO, as it were, even now. Today, it was released in the US, and it will be released elsewhere over the next months. But that was based on a much better understanding of morphology and the epidemiology of clavicular shape and so on and so forth. So I hope I'll be telling you next year that I'm using that plate because I've helped to design it. But we'll see.
Yeah,
we'll see.
Ahmed, بعد إذنك, what about the positioning of the plate?
Right. Well, we, of course, started to think about where are the clavicle fractures actually occurring. And we're always taught that they're in the middle third. But the majority occur at the junction of the lateral 2/5 and medial 3/5. So slightly more lateral than in the middle, as it were. And we've designed the clavicular plate so that it takes that fracture likelihood, the predicted morphology of a fracture, into account. And what's interesting is if you look at small clavicles from Japan and compare them with large clavicles from America and Central Europe, the shape of the clavicle is about the same. It's just the length gets bigger with the larger clavicles. So the twist in the junction of lateral 2/3 and medial 3/5, so lateral 2/5 and medial 3/5 is about the same over all populations. So if we have a comminuted fracture in a small patient, we can use the larger plate from the larger patient to bridge, for bridge plating. But we've also got a smaller plate for the more simple fractures, for the small frame. That's I hope, what will be appreciated in the system is that we can treat small clavicles and big clavicles with bridging and or compression plating using the same family of plates. I haven't explained it terribly well, but I hope that the experience will guide you. But it's in a sense, the plate finds its home on the bone once the bone is reduced.
Okay, I think, thank you very much, Dr. Simon. I think Dr. Sharif Al-Hamri, are you with us right now, or Dr. Sharif? So I think he still has a problem with the internet.
So, I could ask a question to Dr. Lambert?
Yeah, sure. Go ahead.
Could you tell us in the new types of pleats, the direction of the screws will be for the lateral side, in which direction, and for the medial side, from what direction?
So thank you. Yes, the new plate is based on a 2.7 millimeter screw, not a 3.5. So we've been able to cluster the screws closer, but divergent fixation, so that the pull-out strength is much greater than inline 3.5 screws. But they are based on a variable angle technology, so that you can have a 15-degree each way arc of variation. So in the lateral clavicle, you can diverge from the plate 15 degrees in one way, 15 degrees the other. So effectively a 30-degree divergence, which gives you great pull-out resistance. I hope that will, let's say, accommodate for the smaller screw size with apparently less strength, but actually the fixation strength that we've done these tests extensively in the laboratory, demonstrating very great improvement in overall construct stability with this 2.7 clustered and variable angle geometry.
Okay, thank you very much. I think we're now at the end of the discussion because we're running out of time. So allow me to move to that case presentation. So this case is presented is given to us by Dr. Sameh Hulayl, who is a lecturer from Zazi University. So there is this is a 35-year-old female patient came to us after a road traffic accident with the right shoulder that was painful and with abnormal contour. There was also local clavicular and scapular tenderness with swelling and crepitus. So X-ray were done, and these are the X-ray views. So anyone would like to comment on these X-rays? Dr. Simon?
Thank you. Yes, what a case. Hello, Dr. Hulayl. Nice to see you. Thank you for this case.
Hello, Dr. Simon.
Hello. Perhaps the important way to start is how was the patient overall? Did she have other multiple injuries, chest injuries, head injuries, neck injuries, or even a liver injury or something like that? Were there any other injuries, or were these isolated?
No, it was isolated injury, no respiratory or neurovascular injury.
Okay, that's good. So there's a big debate, or has been a debate, about whether one should fix the clavicle and let the scapula look after itself, or fix the scapula and let the clavicle look after itself.
And we're going to move to this question, but
I beg your pardon.
How do you comment on these X-rays? I mean,
got you. Yes. Well, thank you. So there is a relatively simple fracture of the clavicle in its, as I say, the junction of the medial 3/5 and lateral 2/5, and a very complex fracture of the scapula, where there is what we have called the coracoid spur sign, where you see that bone under the coracoid, inferior to the coracoid, as a spike, a bit like the lateral spike of the lateral column. As soon as I see a spike like that under the coracoid, I think that there's a fracture lateral to the coracoid and a fracture medial to the coracoid. So this is now a fracture where the coracoid is suspended from the lateral clavicle with the glenoid, which is also broken, but dissociated from the rest of the body of the scapula. So this would be what the classic description of a so-called floating shoulder, which I'm not sure I really like, but that's what it is.
Okay, perfect. And so, should we look for other things as regard the examination? What do you look for, Dr. Yasser? If you have a patient and the residents came to you with this X-ray, so what would you ask for? No, it's muted. Unmute, Dr. Yasser, please.
You mean as a clinical examination?
Yeah, what would you look for?
First of all, you should expose the patient and look to his shoulder from all directions to compare both sides, to examine the pulse, to check there is no any injury of the vessels, like an aneurysm or so, and to see if there's any tenting of the bone on the skin, which is sometimes, as he's holding and putting his clothes, you do not see this, and after 2 or 3 days you might get a skin injury. And then you test the pulse distally for any changes in both directions and both sides. And this is clinically, but I will order another modality of radiology, which is the CT scan. So you can take
also something. Most of these patients have a brachial plexus injury. I encountered with a high energy trauma like this with the floating shoulder. When we have fracture of the clavicle and scapula, I found that it's often that you can find a brachial plexus injury. So it's very important, the neurological examination, as you all said. So as you said, we should ask for more investigations like like the CT, right?
Yes, but if you look at the X.
Okay, Dr. Muhammad Abdelal.
Yes, sir.
Okay, Muhammad, is it enough for you a 2D CT or you prefer a 3D reconstruction also?
No, it is mandatory to do CT 3D. My question,
okay, perfect.
If we decide to interfere surgically, should we start with the fracture scapula first, then shift?
We're gonna come to this. Let's take it step by step, and then we're gonna go to the management after that. So you were saying that we have to get a 3D reconstruction.
Yes.
Okay, perfect. When you have a 3D reconstruction, do you insist to have a digital subtraction of the humerus? Because most of the CT
Yes.
So, yeah, because most of the CT that we get here, especially in Egypt, that they put the humerus in the
may mask some lesions may be masked by the presence of the humerus.
Exactly.
So insist in the request to do subtraction.
Okay, perfect. Because I'd like to have an idea about the glenoid. So when I order the CT 3D reconstruction, I like to see it from the posterior and the anterior and the dead lateral. Especially dead lateral give me an idea about the glenoid, if there is a fracture inside, and also give me an idea about if there is angulation, and I can measure it. So, so that was the question. What do we look for in the CT? I guess we all answered this question, but if someone would like to comment or add something, I'll be more than happy to hear.
The CT scan just gives us an idea that all the head and the glenoid are pushed inside. There's like medial displacement, all this fragment. The clavicle lateral third of the glenoid, all of it is just like centrally or medially displaced. You should take this in consideration during your reduction. So the CT scan gives us a very nice idea that everything is just spaced inside.
Yeah.
You should. So this comes when you're going to think of the approach, and we'll discuss later on to begin with the clavicle or the scapula.
That's it. That's my question now, as regard the management and the approach. So now when we come to the management approach, my questions are, first, do we have to fix both scapula and clavicle? This is my first question. Second question is, do we start with the scapula or do we start with the clavicle? So I'd like to hear your answers. Dr. Simon, let's start with you. Could you unmute Dr. Simon?
I start with the clavicle first because it's the simpler one. And it also helps the anesthetist because where you splint the clavicle, you improve the ventilation. But it also pulls the lateral aspect of the scapula, the glenoid, laterally as you relocate the clavicle fragments. So I nearly always do the clavicle first. It also means that if you're going to put the patient on the side to do the scapular fracture, which is my preference, the whole forequarter doesn't cave in and potentially cause more trouble for the plexus and the vein. So I fix the clavicle first. That gives me indirect reduction of the lateral scapula to some extent, not all, to some extent, and helps my anesthetist and helps stabilize the retroclavicular space. And then I can take my time over the scapula.
Okay, perfect. So do you prefer to add something, Dr. Yasser, Dr. Muhammad Abdelal? Or you do the same approach and same management, same steps?
Yeah, I agree totally that we begin with the
clavicle and then the scapula.
And we reach the scapula through a lateral approach, putting the patient laterally.
Okay. Now I leave it to Dr. Sameh Hulayl. He's gonna tell us what he did for his difficult case. Dr. Sameh?
Thank you, Dr. Ahmed. As my professor said, I started with open reduction and internal fixation of the clavicle in beach chair position, and I fixed it by 3.5 millimeter reconstruction plate and interfragmentary screw. Next. And in the lateral decubitus position, I start to open reduction and tendon fixation of the fracture scapula through the posterior Brodeskai approach. Next. And this is the post-operative X-ray in the anteroposterior and lateral view. Here, the glenopolar angle increased from 15 degree to 35 degree post-operative. So it was in good alignment. Next, X-ray after 3 months. Next.
So that was the end of your case. So would you like to comment or add something, Dr. Samah?
No, Dr. Ahmed.
Okay. Anyone would like to add a comment or say something about this case or any particular thing with mind?
I'd like to add my great congratulations to a beautiful result. It's interesting. Well, no, not at all. It was very, very well conceived. I like the idea of the plate on the lateral column being lateral, not dorsal, because you get longer screws and interfragmentary compression of your inferior clavicular glenoid transverse fracture. And that's my preferred approach. The only downside is that one almost always either disrupts or gets too close to the circumflex scapular vessels, although I'm not sure that's particularly important in this type of fracture, but it's beautifully done. And it's also interesting to look at the clavicular fracture, which is almost healed, but not quite. And I think it's a case where when just as they say, hold your nerve, because it's going to take another 2 months for that fracture to really unite. But it looks very well done.
Thank you.
Thank you for your comment. Thank you, Dr. Samah, for your nice.
Thank you, Dr. Ahmed. Thank you.
One comment on the clavicle fracture also. If you allow me. In these cases, if you have a choice to use a plate, which is a locked plate, lock screws, and that the direction of the screws, especially in the lateral part, are in different directions, it would be much better to provide more stability. And always take care of your screws, which are on the lateral aspect. If they are a little bit long, they may cause a type of impingement or even injury of the rotator cuff. So if you have other plates, which are lock plates, and those which have screws 2.7 on the lateral aspect, it might be much more suitable for early mobilization and healing.
Okay, thank you very much. I would like to thank all the speakers for their nice presentation and their nice comments. It was very fruitful. Actually, I gained a lot from your lectures and your comments. And I would like to thank COB for organizing this webinar, our 7th webinar. And also, I would like to thank Eva Pharma for sponsoring this webinar. And I think we're going to now move to Dr. Mina from Eva Farm. He's the regional product manager who will give us a talk about thyroid seed. And thank you very much. Thank you, everybody.
Thank you.
Dr. Mina, we cannot hear you. Dr. Mina?
Are you hearing me now, Doctor?
Yes, now we can hear you.
Great. Thank you very much, Dr. Ahmed, and greeting to all doctors and all panelists. It is our pleasure to be with you in this webinar as well. We are using to be with you and with EGSSA Association every now and then, and we are very happy to be with you. And I would like to congratulate all who are working on this, on such series of grateful webinars, very informative, as all the panelists and all the attendees have shared their comments. I'm very happy to be with you this night, and I would like to share with you some points regarding one of very important products in Eva Pharma, which is thiacid. Indeed, over the last presentations, we have talked about thiacid in many directions. And today as well, I'm going to share with you some important points about thiacid, not only in neuropathy due to nerve compression, but also, as the title of my presentation is, neuropathy treatment of various origins. So we are talking about peripheral neuropathy, and there are many causes of neuropathy. Diabetes is one of the most important and common causes of neuropathy, maybe 50 to 70 and more than that percent. Diabetic patients are suffering from neuropathy due to the complications of diabetes, also infections, autoimmune disease, inherited disorders, and for sure tumors, either malignant or benign, may develop on the nerves or press the nerves and its roots as well, causing neuropathy. Some bone marrow disorders and other diseases like kidney or liver disease or hypothyroidism as well. Also, other causes in some countries, increased intake of alcohol may be some of the causes of neuropathy. Exposure to poisons in some areas with high pollution. In these cases, heavy metals are leading to toxin neuropathy. Some medications as well, and the trauma or pressure of the nerve. Maybe you see a lot of cases in such cause due to tumor on the root of the nerve, and as well some vitamin deficiencies, especially B vitamins. And in some cases, I'm sure you see some cause of neuropathy without reason, which is idiopathic neuropathy. What I want to say is that in these cases, all cases of neuropathy, the pathophysiology, the underlying pathophysiology may be overlapped in the same area, which are oxidative stress, as you see in different causes, in even neuropathy due to chemotherapy, and here is due to compression, or even in the pathophysiology of diabetic neuropathy. The nerve are exposed to oxidative stress and resulting in some sort of inflammation and inflammatory cytokine storm and triggering of inflammatory mediators, resulting in some manifestations in the vascularity of the nerve and hypoxia and decrease in the blood supply to the nerve, resulting in some manifestations as demyelination or axonal degeneration of the nerve, and at the end, dysfunction of the nerve. As you see, here is the path of the nerve from the healthy state, as you see, to diseased blood vessels and affecting the circulation of the nerve, and at the end, demyelination and dysfunction of the nerve. So we can stand together on specific points regarding the pathophysiology of neuropathy, which is inflammation and oxidative stress, as we have mentioned, passing through microvascular change and for sure nerve hypoxia, and at the end, demyelination and axonal body loss results in dysfunction of the nerve and appearing of, along this journey, appearing of symptoms of neuropathy. And as usual, I'm hitting on thiacid as a powerful combined actions for treatment of neuropathy by its active constituent, which is alpha-lipoic acid or thiactic acid, because this molecule is pleiotropic compound that has many mechanism of actions targeting different directions of neuropathy. Just mentioning that it is alpha-lipoic acid or thiactic acid, and it is already sensitized in the liver, but the patient with neuropathy needed in higher therapeutic dose to give its therapeutic effect. A very specific character of alpha-lipoic acid or thiactic acid in thiacid that is amphiphilic, which is both water-soluble and fat-soluble, giving advantage to thiacid to reach the reactive oxygen species, ROS, or free radicals in intracellular and extracellular spaces. By its specific mechanism of action, thiacid can target different mechanism or pathophysiology of neuropathy, passing through its vasoprotective effect, neuroprotective effect, or even one of the most powerful known antioxidants effect. Vasoprotective effect, it can improve the blood supply, restoring nitric oxide, which is an important vasomedilator, vasodilator agent, and being a potent antioxidant, preventing the adhesion of free radicals and toxic metabolite to the wall, the inner wall of the vasa nervorum, especially providing a smooth blood flow to the peripheral tissues. And as anti-inflammatory, it inhibits the activation of nuclear factor kappa B, and for diabetic patient, reduce the binding of the advanced glycated end products specific for diabetic patient. For neuroprotective action, it regenerates the damaged nerve fiber, it improves the nerve conduction velocity, and increase the nerve growth factor, which is an important factor for remyelination and the sprouting of nerve axon as well. And at the end, being a cofactor in Krebs cycle, it can enhance energy production and provide the energy with the energy, provide the nerve with the energy important to perform its function in nerve conduction, in nerve signal conduction. And the last action of cytosine, which is the antioxidant, being a universal antioxidant and one of the most powerful antioxidant known till now. It is a potent free radical scavenger and metal chelator as well, which is very important for cases of poisoning neuropathy. Not also being an antioxidant, but it can recycling other exogenous and endogenous antioxidants like vitamin E and C, exogenous ones, and the intracellular glutathione, which is a very important intracellular antioxidant. So by this, cytosine, by its specific mechanism of action, can hit the pathophysiology of neuropathy from different causes, vasoprotective for microvascular changes, neuroprotective effect for injury and demyelination, and the antioxidant anti-inflammatory effect for the oxidative stress and inflammation. All these points are very important for patients and clinically evidenced by different effects of cytosine or alpha lipoic acid in different causes and different figures of neuropathy. Here is one of the most recent clinical trials on the effect of alpha lipoic acid on what? On symptoms and the quality of life. By targeting quality of life, I mean the pain score, the total quality of life of the patients. Here is in painful diabetic neuropathy. And as you see, the work disability, the social life disability, and family life disability scores were significantly reduced by using cytosine or alpha lipoic acid over 40 days. This is what I want to mention, that many patients have related their health condition as very much better or much better. And this is the aim, I'm sure you agree with, the aim of any treatment, to improve the quality of life of the patient. Not only this, but also reduction in neuropathic symptoms, which is pain, tingling, numbness, burning sensation for patients. Here is for patients suffering from diabetic neuropathy. And the conclusion was that alpha lipoic acid administration was associated with reduced neuropathic symptoms. Not only this, but as well triglycerides, and at the end, improved quality of life. A very important note is that whenever clinical trials are talking about cytosine or alpha lipoic acid, a specific word is related to this molecule, which is pathogenetic treatment for diabetic neuropathy. Pathogenetic treatment means that it is targeting the pathophysiology of the disease, not only reducing pain or masking the pain the patient suffering from, but also it is targeting the underlying pathophysiology. As you see, all papers are talking about the pathogenetic mechanism or pathophysiology or pathogenetic treatment of diabetic neuropathy, as you see in different cases. And that is why different guidelines are recommending cytosine or alpha lipoic acid as a pathogenetic treatment, maybe the first line pathogenetic and also the only line, because it is the only approved as pathogenetic treatment for diabetic neuropathy. Here is for diabetic patients and other causes such as nerve compression, as well for patients suffering from sciatica, improvement in neuropathy impairment score and in neuropathy symptom score, and as well total symptom score for patients using Cytosine suffering from sciatica, and also the important point, which is decrease need of analgesics. It is very important that treating the underlying pathophysiology results in improving the case and decrease the need of analgesics, which is a great success for patients suffering from neuropathy. Not only this, but recovery of nerve functionality and decreased neuropathic pain for patients suffering from sciatica. As well, for patients suffering from low back pain, improve functionality and reduces use of analgesics. For carpal tunnel, as I mentioned the last time, and again another trial, that patients using alpha-lipoic acid generate improvement in symptoms and functional impairment, and as well significant reduction in Boston carpal tunnel questionnaire and in pain numeric rating scale. As you see, there is improvement in the pain without giving a painkiller, because we are treating the underlying cause and improving the oxidative stress and the inflammation in the nerve. Here is the conclusion of the clinical trial on carpal tunnel and nerve decompression that recommended alpha-lipoic acid or cytosine as a standard protective post-operative supplement after carpal tunnel surgery to improve the functionality of the nerve even after medial nerve decompression. So, starting from this, cytosine is recommended for different diseases of neuropathy from different causes: diabetic neuropathy, nerve compression, idiopathic even, or poisoning neuropathy, or chemotherapy-induced neuropathy. There are many routines using cytosine or alpha-lipoic acid in these cases, just to ensure that cytosine is very safe for different populations: elderly patient, renally impaired patient, liver function impaired patient, or cardiac hypertensive or diabetic patient. No need for dose adjustment. Please be sure that it is very safe. Over more than 60 years, when it has been firstly approved for diabetic neuropathy in Germany in 1958, no claim on cytosine or alpha-lipoic acid up to that the lower dose, which is 300 milligram, are sold over the counter in America for its potential antioxidant effect. Just reminding with the dose, the therapeutic dose ranges between 600 to 1800 milligram per day according to the case severity, and all doses of cytosine to be taken on empty stomach. For mild and moderate cases, we can start with 1200, and for severe cases, we can start for 1800, and as a maintenance dose, 600 milligram once daily. For diabetic patient, I think we need longer cytosine for life for diabetic patient because diabetes is not cured. And for other causes, till we have treated the main cause of neuropathy, which is maybe nerve compression or such cases. Again, the patients are suffering from very painful nerve ending, and this is a motive why they come to the clinic asking for a treatment to treat this pain. Treating the pain by treating the underlying cause of the pain and the underlying pathophysiology of neuropathy is a success in order together to reach with the patient to the best results. We have in Eva Pharma other portfolio for a neuropathy, or I'm sure for you professors as orthopedics and orthopedic surgeon, Sympatex, which is duloxetine. In some countries, it is registered, and Conventine as gabapentin for neuropathic pain modulation. And as well in other countries, we are registering Genofil as a triple combination for osteoarthritis, glucosamine, chondroitin sulfate, and MSM. Thank you very much for your patience and for your listening. And thank you, Dr. Ahmed, and all the panelists and all the attendees. The mic is yours.
Thank you, Mina, for your presentation. And I'd like to thank you again, and thanks to Eva Pharma for sponsoring our webinar. I think we come to the end of our webinar. I would like to thank you all, and stay safe and stay tuned to our next webinar next month, inshallah. Thank you very much.
Good night.
Good night, everyone.